So, I said yesterday about the treatment of hypertension as the best measure for vascular disease, and indeed it is. But let's talk a little bit more about those stuff. Okay. Yes, as I wrote a paper with Philip that we do not believe too much in type 2 diabetes as a mainly or a primarily sugar disease. We don't think this way. We think there are much more deeper problems, metabolic problems and other kind of problems. To start with, we need to know this. When I deal more with diabetics over 6.0 years old. And we need to know this. When we get older, we need higher cholesterol levels. When you get older, our blood sugar goes up of everyone here, okay? It does not mean that it is a disease. If we think that prediabetes is a disease, we're gonna have the whole population of adult population of China with prediabetes would be 500 million people in the globe, and there is no evidence that it causes retinopathy, neuropathy, cardiovascular disease. Even the best cohorts do not show this. So this is an industry-driven disease, okay? And namely based because they do not want us to know this. When we get old, we need higher levels of certain parameters. I'm going to show you which parameters, okay? So, when people over 60 years they are thin, they have low cholesterol, low blood pressure, low glucose, and a higher than normal GFR, they are not in good shape usually. There is a U-shaped relationship, okay? Yeah, U-shaped mean that it cannot be too low. It cannot be low, okay? It should be higher than the young people, less than 60 years. Let's put the cutoff line around 60 years. And people gives a lot of mechanistic explanations for this. Stay away from those mechanistic people. They have a mechanism for, they have a mechanism for everything. They don't like to watch the nature, what the nature is telling us, okay? Yeah. Probably there's a turning point at a certain age when those risk factors change from unfavorable to favorable for survival. This was written by a mechanistic author. He was co-author with me on a recent paper. He is very mechanistic. I'm not. Okay, but we see more papers from people who are not mechanistic ones. And I told you, stay away from these people because physiology papers, I'm sorry to say it, physiology papers not. Physiologic evidence is not evidence. We need to practice evidence-based medicine based on hard outcomes. That's the best way, I think. I'm sorry, Luis, I did not talk against physiology, okay? I was talking about evidence-based medicine. Let's go ahead. So this is a recent paper. I would not say, but one of those authors should be like a very rich person because I requested to him some papers. He never gave it to me 1 week before this meeting, he started to send me the papers, okay? He has something which is best known as the obesity paradox. He gave his own name. He has his own line of research. I think he has even an NIH grant with his name. Yeah, it doesn't matter. This is the paradox of all the traditional cardiovascular risk factors in the geriatric people, those over 60 or 65 if you wish. If you want to be a bit more conservative, you can say over 65 years. But they are epidemiological study, so you cannot base your treatment on those data. But it's much better than you speculate with mechanisms, which is much worse. But we need to respect what nature is telling us. So, this is body mass index. There is data with this, with waist, circumference, and everything. There's a U-shaped relationship. With glucose the same way, with blood pressure the same way. You see here, when the body mass index begins to increase, you see the risk for mortality, you know what I'm saying, start decreasing. Yeah, this is true also for waist circumference. You see, it start to increase. This is for males, for men, very close to the metabolic syndrome waist circumference. People start, okay, to live more. Yeah, and look, for cholesterol, the same thing. Quite interesting. You see, the old people who are thin, they have what we call the frailty syndrome. We have to respect that. People above 60 years who live longer, they have a body mass index above 25 and below 35, 32, and usually have a healthy lifestyle. It's not only this, but they cannot have a normal body mass index, at least the whole. This is like moderate drinking that increases survival. Every kind of epidemiological study in India, in Africa, in Brazil, in Israel, in Italy, they show the same thing. I hope my English is okay. You see, people, you see, with lower cholesterol, they die more than people with higher total cholesterol here. But you need to tell this to the American Heart Association, to the American College of Cardiology. They want to put statins on the drinking water. But this is not true if you have more than 60. We need cholesterol, at least to make cortisol, at least to make vitamin D, at least to have a good sexual life. We need cholesterol for that, at least, okay? But you see people with lower cholesterol here below 160, they die more. It means they live less. This is the hardest endpoint in medicine. The same for, this is a quite inverse graphic, but the same for systolic blood pressure, you see? We don't need to allow the people to be very hypertensive above 60 years, but we need to leave them have a good systolic blood pressure. That's the big difference from the GNC8 to the GNC7. That's fine. But people don't like to say those things. People don't like to investigate those things. They prefer just to ignore or to give simplistic, mechanistic analysis for those. Now, who can tell me who is this guy here? Can anyone tell me? Maybe our colleague from... No, nobody. Oh? An actor. Okay, you're going to see him. There's this guy when he was younger, you know? Yeah, he was the great inspirer for the national health system in the UK, okay? He was twice a war prisoner of the Nazi. Kind of interesting. So he noticed that on a camp, I think with 2,000 or more prisoners, in 1 year, only 4 died. And 2 died of lost shots, and 2 of diseases. So he started to think, so I think, no, it's not anyone that can get a disease. So and the resources to treat people are limited. So I think we should do a more scientific way to see those things. He started to put seriously in practice the idea of randomized clinical trials. He had porphyria. He had sexual impotence. When he died, he put that on, I don't know, his thumb. We say that. That's the name, I don't know. That unfortunately, he never had in his life the love of a woman. He started doing psychoanalysis and did not work for him. He was very rich, let's say, by the way, but he was grateful for his life. And before he died, he said a lot of bad things about Sigmund Freud and others, okay? But this is a great person. He fought against the dictatorship of Franco and of Adolf Hitler. Great person. So he said this. This was his main work, 1971. You see how bright people, they have a simple way to express themselves. Any kind of medical intervention or drug, we need to ask those simple questions. That's in his main publication. Can it work? Does it work in practice? Is it worth it by the end? Okay? He's a monster in medicine, let's say this. So he said that every medical information to be considered effective ideally should be demonstrated by a randomized clinical trial, that this intervention does more good than harm. People forget this a lot nowadays. This criterion should be applied not only to new treatments, but also to old treatments, the use of diagnostic tests, and screening procedures. When he came back to London, the Royal College of Physicians, there's a whole majority idea that the diseases came from the gods. So he had said, no, this is science. This is a bit different. This is another difference by an author from the journal that I work in. He thinks the same way as Philip said, and by the way, most of it, yes, it is. It's a disease of modern times, yes. It's a plague, oh yes. It's the interaction of lifestyle and other stuff. If this is true, yes, I think. If progressive, if this is true, I don't know, because it's always progressive, I don't know. I had some slides here that shows that it can be not progressive, can be reversible without drugs, but would be too long my talk here, okay? The same author, the polypharmacy of chronic disease is the lottery of drug industry, and no more with diabetes. Yes, it's the disease who makes more profit nowadays about the pharmaceutical companies. With new drugs, the increasing use of analogs of insulin, tens of billions of pounds, not US dollars here, pounds, I think worth a little more than the dollar. And so the complexities, look here, what a wise words. And so the complexities of diabetes are reduced to simply lowering blood sugar. In my opinion, it's just like drying ice. It goes to nowhere, okay? So here, a recent paper also. There are surrogate endpoints, very poor surrogates. HbA1c, as Philip said, blood glucose. There are soft endpoints that doesn't mean a lot. Microalbuminuria, as I said, is not a disease. And the hard endpoints that matter to patients, those are that matter, but those takes longer to appear when you start using a new drug. Okay, this is another author from the UK. And he started criticizing those intensive glycemic control strategies. And he said that people got hysterical with him. So he gave the name glucocentric diabetologist. Well, this is the guy, a great one. Because you see, I don't see glucose here. I see white body fat. I see lots of brown fat cell, lots of white fat cell. This is the big enemy, as my colleague from Israel said. This is the good guy. This is the bad guy. This may transform into this. Very well said by cold weather. He said noradrenaline, you said about this, to stimulate? Yeah, the brown, yes, yeah. But cold weather also, and a healthy lifestyle also. This is good, and this is a very dynamic. One can go to other and vice versa. But this looks more, I know I'm being very deterministic here, very mechanistic. It's not only diabetes. There's a whole bunch of other problems to get diabetes, including living in a poor neighborhood is a strong risk factor for diabetes, okay? If you live in a wealthy neighborhood, the chances for you getting diabetes are much lower. Am I okay here with the microphone? Is it okay, Ricardo? Okay. So look, this is a natural experience. This was 8 million rats. I think there is no lab with 8 million rats. It was in Cuba. You know, Cuba was heavily, it's okay, the microphone here? Cuba was heavily supported for decades by Russia, the Soviet Union. This was published very recently at the British Medical Journal. Very interesting article, very interesting. Then Gorbachev reached the power. The wall of Berlin went down. Then Cuba entered into a very deep recession. Then people started eating less and biking to go everywhere, going to work, going to leisure, everywhere. So let's look here. Then the recession and the US and the Soviet Union went down, okay? In Cuba also the recession went down, and biking in Cuba is considered a bad attitude. It's considered an attitude for lower income people. So they stopped biking. And let's see what happens here. So this was from the paper, okay? People biking a lot in Cuba. You see, healthy lifestyle, in other words. You see here, body weight increased and body weight started to decrease. You see? No. Physically active individuals, dietary energy intake. So they started to become more physically active and eating less. Okay? Then they decreased physical activity and started eating more. Okay? Cigarettes, decreased also. This is good, right? People didn't have the money to buy cigarettes also. You see the body mass index came to the left because of eating less and doing more exercise, namely because of the biking. You see, obesity came down, you know. Then, when the recession stopped, okay, the prevalence of obesity started to increase again. Diabetes also, the same goes the same way, you see. Going down here, people start eating more diabetes and gaining more weight. People start getting more diabetes. Diabetes is very much correlated with weight and the short term, much more than vascular disease. Must be other pathways other than just insulin resistance. Obesity prevalence, okay, comes down here. Diabetes also comes down. Starts to come up, obesity, diabetes starts to come up again. The same about mortality, okay? When it comes down, the weight, mortality from coronary heart disease comes down. Kind of interesting. You don't think, Philip? A natural experiment in Cuba. We have a lot of different things in Cuba. So close here to Florida, right? You never went to Cuba? Cuba, does anyone here went to Cuba? Never, okay. I'm sure you saw many interesting things there, okay? So we found that a population on a run loss of 4 to 5 kilograms, not that much, in a relatively healthy population was accomplished by a falling diabetes mortality by half. You see, this means a lot. And from coronary heart disease by a third. Okay, thank you. Not go a long way. You see, this means a half is much more than a third. So it means that regarding vascular disease, you see, glucose is good for diagnosis, but not for treatment. You see, this is a big difference. Also in hypertension treatment, you reduce stroke by a lot, but not coronary heart disease by a lot. Those are more complex things. A rebound in body weight was accomplished by an increased diabetes incidence and mortality, and a deceleration of the decline in mortality from coronary heart disease. You see? Yeah, I think diabetes is a very complex disease, not only glucose, I think it's a epiphenomenon or a paraphenomenon, speaking more clearly. And we have the white adipocyte, we have having a bad lifestyle, living in a poor neighborhood, having too much blue lights on, lots of things. Okay? So these data are a notable illustration of the real cardiovascular disease health benefits of reversing the global epidemic of obesity. So what are we missing about microvascular disease in type 2 diabetes? Well, this is just a cartoon. We have food security, or better, some could say food insecurity, okay? Because poor people, when they have some money, they go to eat junky food the whole day. We have, for sure, an obesogenic society. We have sedentary lifestyle. Perhaps, yeah, sedentary lifestyle is terrible. We have the bad white adipocyte. We have those peripheral things that act later to aggravate atherosclerosis, but we have inflammation working earlier. This is a working hypothesis, and this goes to type 2 diabetes. But you see, this is completely independent from insulin resistance. We have a completely different pathway to vascular disease that does not depend on insulin resistance. I come here I try to put people to think about things. Sometimes we do not have the answer, but we need to think. It's only insulin resistance, the whole answer. I do not believe on that. I think there are other factors. Maybe we have different pathways for that. Okay? So this is my final slide, I think. So do we need targets for type 2 diabetes? The issue of my lecture? I don't think so. Forget about targets. I think we need goals. We do need goals for that individual. Talk with them and share the decision with the owner of his own health, which is that individual. This is the best way to go ahead. And thank you.